Thank you, BOS, for giving this opportunity again. And today I'm going to be talking about decompression for spinal canal stenosis using the full endoscopic approach. We've seen brilliant talks of decompressing the canal with the open techniques, with the tubular techniques. So then why should we then venture into endoscopic? When we're doing a discectomy, we know the advantages are that we don't have to remove the phlegm, we don't have to do any laminotomies, etc. But when we are decompressing, we are removing the phlegm, we are removing all offending structures. Then why should we go the full endoscopic way? Well, to start with, one, the amount of lamina also required to decompress the spine is significantly less because the instruments are much smaller and we don't need that much space to go into the canal to remove the phlegm. So the amount of lamina removed is less, which hopefully will save a lot for the patient's future. The visualization is fantastic. The magnification is very good. You can see the smallest adhesions, the dural adhesions. And we are also using continuous saline irrigation, which I feel also creates a plane between the phlegm and the dura, which I think because of which we have lesser incidences of dural tears as well. And if a tear does occur, because the amount of space, the amount of dilation is so less, that invariably after putting a tissue, I've never had any post-op complications secondary to dural tears. The scar formation also is less, and overall the length of the scar also is significantly less. The instruments are similar to what we use in for discectomies as well. However, I prefer to use a bigger size of scope, which is a stenoscope, which has a 5.7 mm working channel. For discectomy, I use a 4.1 mm. But however, in this case, I use a bigger one because I can use slightly bigger instruments, which makes the surgery faster. Can we use a smaller scope? Yes, we can. However, the instruments used are much smaller and the surgical time therefore increases. A radiofrequency cautery is a must. And obviously, when you're dealing with stenosis, you need to have a fantastic burr system. And that's one of the most important instruments required during stenosis. The setup is similar to discectomy. If you're standing on the right side of the patient, then the CM and the monitor are on the opposite side. I usually keep my RF and burr towards the leg and the irrigation from towards the patient's head end. For stenosis, the positioning difference is as compared to discectomy is that over here, I maintain the lordosis. In discectomy, we try and open up the spine and interlaminar space, so we flex the patient more. But in stenosis, I maintain the lordosis as I feel that by opening up, we land up under decompressing. The entry point is also similar. It's in the interlaminar space. Sometimes I also take the entry point at the junction of the superior lamina and the interlaminar space in cases where the interlaminar space is less. Once the entry point is taken in AP, then the dilator is inserted, and with the dilator, we use a dilator to scoop off the muscle off the lamina and also to feel the bony landmarks, the facet joint, the superior lamina, the inferior lamina, and then you dock the dilator at either the junction of the lamina and the phlegm or in the interlaminar space if it is big enough. The working cannula is then inserted, and over here as well, we use a bevel cannula, which helps us protect the nerve roots and also gives us a good visualization all around. The endoscope has a working channel of 5.7 mm for in a stenoscope. Similarly, that's the camera and the fluid irrigation. Again, the flexibility is what is the most important. As you see here, we can go superior, inferior, medial, lateral, over the top, and we can also zoom in and zoom out as and when required. After this, the next slide, I'm going to start showing you where exactly and how the burring happens. So once we feel the interlaminar process of the phlegm and the lamina. Then we feel the lamina, we feel the spinous process, we feel and we scoop off all these muscles. Once we have done that, I try and find this ridge, which is the medial part of the facet. And once I have seen that ridge, we remove the soft tissue over there. We see the lamina over here. We see the interlaminar, the phlegm, interlaminar space. And that's when the burring starts. The burring usually starts at this ridge on the medial aspect of the joint. So we start the burring from the medial aspect, medial part of the medial joint, and then we can go superiorly on towards the lamina, if required, under process of the spinous process, and then finally towards the inferior part of the superior part of the inferior lamina. Once the burring is done, only then we start removing the phlegm. So once I have docked my my endoscope inside, soft tissue clearance is of utmost importance. All the bleeding should be tackled with the radiofrequency cautery. Don't try and remove any soft tissue without getting the bleeding under control. Otherwise, once it starts bleeding, it gets difficult to manage it. Once that is done, we try identifying the landmarks. So using my cautery, we also feel, I know where exactly my medial facet is, where my lamina is going to be, and then start scooping off the soft tissue. So here I can feel the medial part. I feel that this is soft, so my interlaminar space is here, and this is where my lamina is going to be. So this is the lateral part, that's medial, that's superior, and that's inferior. Once that is done, the soft tissue around the medial part, so we need to remove the soft tissue before we start burring, otherwise the soft tissue can get entangled in the burr. Once that is done, the burring starts, and the burring starts from the medial part of the facet, and then it is taken superiorly towards the lamina. Then we also go laterally to try and remove the amount of medial facet as and when required, depending on the space which you have. Always keep on using a cautery whenever you see smaller bleeding vessels, otherwise the visualization gets affected. So this, I'm going medially, laterally towards the other side. And once I've thinned out my superior lamina and my facet, that's when we introduce the kerison. And the other part of the lamina can be further burred down using the burr. This is also the part of the superior facet now, which I'm going to burr. We also have these oval burrs with side protections, which are also helpful. So once the burring is done, then I detach the phlegm from underneath the lamina to try the space. You use the nerve hooks as well to look for any adhesions. And then the kerisons are introduced to remove the ligamentum phlegm. I also use annular cutter to thin down the ligamentum phlegm, especially when the ligamentum phlegm is very thick. And before every step, we are checking whether the phlegm is stuck to the dura, and only then the phlegm is removed. Now I'm on the lateral edge of the nerve. And once we see that, once we finish that as well, we start seeing the lateral edge of the nerve, and that's the superior, the superior facet here, and the phlegm underneath the facet. When that is done, we see that the whole nerve is free. We can see the whole lateral edge of the nerve. The nerve can also be easily mobilized. That's the disc down there. If required, a discectomy can also be done from here. And from here, the lateral recess further can be decompressed if you feel it is compressing the nerve. This is mainly when I'm just showing you a video of just one-sided lateral recess decompression. This is what you should start with on the initial days. This is where the pedicle of the lower, part, which is over here, and you completely do a pedicle to pedicle decompression. In this case, I didn't need to go over the top, so I'm not going to remove the central phlegm. Neither I have decompressed the part of the spinous process. So as you see here, I've gone right from the superior, the exiting nerve, right until the lower pedicle. As and when you start getting better, then you can take tougher cases with complete central compression as well, where you need over the top decompression. So this is the base of the spinous process, and I'm using my burr to thin out the base of the spinous process. And once that is done, we start removing the ligamentum phlegm from underneath the spinous process to do a complete thorough decompression. So you're already seeing that the central dura is decompressed, and that is the opposite side where the opposite nerve is going here. And the main reason here was doing a thorough central decompression. Here I'm again on the ipsilateral side, so I'm seeing the ipsilateral side. I'm seeing the central dura as well. I can see the pulsations of the dura already. Centrally, the dura is completely decompressed. That's the beauty of the scope. You can zoom in, you can zoom out, you can rotate the scope to go in and look in the ipsilateral lateral recess to do further. This is on the ipsilateral side, where I'm removing a little bit more of the superior facet. And So the endoscope is definitely helpful in the situations where you can go into every nook and corners, right from the ipsilateral side, as well as to the center and to the opposite side of the dura. Similarly, a case of a fascial cyst over here. So here also we need just ipsilateral decompression of the fascial cyst, patient having significant left leg pain. And as you see here, the process, the steps are going to remain the same. Decompression of the lamina of the ligamentum flavum, and then you go down as and when required. I'm able to forward this video for some reason. So as you can see here now, we are decompressing the cyst. And after decompression of the cyst, you see that now this is again the advantage that you can rotate the camera and go underneath the lateral recess to visualize for any further ligamentum flavum or superior facet compression. And that is the disc below, and the nerve is completely free, and even the cyst has been completely removed. So it is a familiar approach. The exact steps what to do with the open case or using tubes, the same steps are done using the endoscope. You can always convert it to a tube if you ever struggle. As I said again in my earlier lecture, that you need to know how to do an open decompression followed by a tube decompression. Only then I would advise you to go into a full endoscopic decompression. Start with observing a lot of cases, looking at videos. Once you know that you know the anatomy without asking the surgeon, which is the right, left side, what is superior, inferior, that means you know that you mastered the anatomy. And that's when I would advise you to go for cadaveric courses. Start with discectomies only, then go for migrated discs, then start with lateral recess stenosis, increase your indications as per your comfort then, and then go for significant stenosis. Thank you very much for your time.